Hello there, welcome back. This is the third and final video in the CBCT topic. We're going to cover three things. First of all, the artifacts you'll see in CBCT scans. Second, your legal responsibilities for interpreting them. And then a brief mention of other advanced imaging modalities you might encounter as a general dentist. So a quick foundation point first. We mentioned voxels in the last video. A voxel is just a tiny cube of data, the 3D version of a pixel. The size of the voxel sets the resolution of your scan. Smaller voxel means higher resolution, but also more dose. Most dental CBCT machines let you choose voxel sizes from 0.07 up to about 0.4 millimeters or so. Smaller voxels are appropriate for things like endodontic evaluation, where you need to see fine detail, whereas larger voxels are for implant planning, things where you mainly need accurate bone measurements, impacted teeth, things like that. So the reason this matters for artifacts, smaller voxels means you see more of certain kinds of artifacts because you're trying to resolve smaller things, but larger voxels hide some of those artifacts because they average them out. So it is a trade-off. So now let's get into artifacts, which I like to call the Achilles heel of CBCT imaging. And specifically, I'm referring to dense object artifacts, but there are several types that you'll see and you'll need to know. So I'll go through the main ones here. First of all, patient motion. Patient movement is the artifact that denigrates CBCT images more than anything else. So even patients who think they're holding completely still typically aren't. Sometimes they look like this, but hopefully not that bad. Studies have shown that teeth actually move in sync with the heartbeat up to 80 microns, so small movements are inevitable. But big movements like this are going to ruin the scan completely. And what does a movement artifact look like? Well, typically it occurs just like you see here. It's almost like you're seeing a double contour of all the structures. Here we see everywhere. Sometimes you'll see it just localized to one area if they just happen to move and move back. But if the patient moves, if the patient swallows, sneezes, or shifts during the scan, you'll see it and it'll show up like this. So the best machines are going to have some type of stabilization, whether it's just a chin rest, a head rest with a bite block, or full head rest like this, the forehead rest. So you can see there's various types of these, the head straps, stabilization handles, all those things are to help stabilize the patient. And if you're buying a CBCT, that might be one of your considerations. All right, this is the big one, and the one I typically refer to when I'm saying the Achilles heel of CBCT is metal or dense object artifacts. Those create beam hardening, scatter, cupping. Anytime you have something really dense, especially metal restorations, it creates dark bands, bright streaks as we see here, and distortion, usually just through the axial plane though. And so get used to what it looks like. Streaks radiating out or in between two different metallic restorations, distortion around the metal itself as we see here. Patients with multiple crowns or amalgams get very bad artifacts, patterns that can completely obscure structures beyond recognition. So someone with a lot of the metal in their mouth, it's going to be really tough to diagnose caries. And caries diagnosis in CBCT is a lot of times helpful as an adjunct to other modalities. Sometimes you'll see things that you don't otherwise, but it's often subject to these artifacts, especially around metal restorations. Root fractures may be obscured by gutta-percha, posts, or core buildups. Implants show notable artifacts, especially between two adjacent implants. Sometimes makes it even impossible to see bone between implants. So recognize when an artifact is hiding something and know how to correlate with 2D imaging and clinical evaluation. Remember how I said 3D and 2D imaging are complementary? And different machines are going to handle these artifacts differently. Some have artifact reduction algorithms, but none of them are going to completely eliminate these metal artifacts. All right, next one to know is partial volume averaging. And that happens when a structure is smaller than the voxel size, or when a voxel straddles a boundary between two different tissues. So the voxel ends up being averaged, or an average gray value, that doesn't represent either tissue accurately. So what you see is edges that look stepped or pixelated. Small structures appear to fade in and out, boundaries that look smeared. Sometimes you have a really thin cortex that's just too small to be picked up in the resolution of your scan. And that still could be considered volume averaging. But remember, you're always going to pick the voxel size appropriate to what you need to see. All right, third one here is ring artifact. We got our Lord of the Rings ring up here. And so it's just like it sounds, right? A ring centering around the center of the scan. It's a circular shape on axial images. And these arise from imperfections in the detector or poor calibration. So if your machine constantly shows these ring artifacts, you're in need of calibration and servicing, and that can get rid of it. All right, next one to know here is scatter and noise. Scatter is X-ray photons bouncing off something and hitting the detector at a different point than it would have on a direct path. And CBCT is more prone to scatter than medical CT because of the cone-shaped beam as opposed to the fan-shaped beam that they have in medical CT. But in CBCT, we're exposing a large volume all at once, and that's why it happens. So scatter shows up as this graininess in the image. We call it sometimes quantum noise. The lower dose means more noise. So you're always thinking about the signal to noise ratio. Higher dose means less noise, but more radiation to the patient. So again, a trade-off at the heart of CBCT optimization. You always want to use the lowest dose that still gives you a diagnostic image for the purpose that you're taking the scan. All right, so do be able to recognize these different artifacts. When you look at CBCT cases in my course, you'll see all these artifacts at some point. Streaking from crowns and root canal posts, blurring from patient motion, pixelation from partial volume averaging. Don't mistake artifacts for pathology. If something looks suspicious, but it's right next to a metal restoration with a clear streak pattern in the axial direction, it's probably an artifact. So the general rule is if a finding only exists in one plane and it disappears when you switch to a different plane, suspect artifact. But if you can see it in different planes, and sometimes I've been able to detect caries right around metallic restorations because I look at the other planes and the caries really stands out. And so if it does persist, then it might be caries or actual pathology. All right, this part of the video is really important. I want you to remember this: legal responsibility for CBCT interpretation. When you order or take a CBCT, you're the one legally responsible for everything in the volume, not just the area you ordered the scan to evaluate, but everything, the entire data set. That applies to general dentists the same way it does to me as a radiologist. And so why does it matter? Well, a CBCT volume contains a lot of incidental findings: sinus pathology, TMJ abnormalities, calcified carotid arteries, cervical spine anomalies, pathology in the ramus or condyle, in the brain, airway abnormalities. Any of those can be present and clinically significant, and you are legally responsible to identify them or have someone else identify them. There has been cases where dentists were held liable for missing carotid calcifications, sinus malignancies, cervical spine pathology, all visible on the CBCT that was ordered just for implant planning. And so the way to make sure you don't miss anything important is a systematic approach. I want to talk about these two principles. First, look at every slice in all three planes: axial, coronal, sagittal. Don't just look at the implant site. Don't just look at where the symptoms are, but look through everything. Sometimes it helps to divide it into thirds when you're scrolling because your eyes can't see all of an image at once, but you're constantly scrolling through back and forth and probably several times in each plane. The second one is have a checklist of structures to evaluate: the oral cavity, sinuses, nasal cavity, skull base, TMJs, cervical spine, and all the soft tissues. And of course, when you have your checklist, it'll probably be a lot more detailed than this. If you want an example of one, reach out to me. I can send you a checklist that I made early on. But basically, if you don't feel comfortable doing this for every CBCT you order, that's where you refer to a radiologist. There are many radiologists that read CBT scans for a reasonable fee. Now, we've all taken the dentist pledge to benefit our patients according to our greatest ability and judgment and to do them no harm or injustice. You probably said that pledge twice during dental school. So ensuring nothing important on the volume gets missed is part of that pledge. Interpreting a volume you're not equipped to read is not confidence. It's the opposite of the judgment that we promised. And I've seen too many cases where significant findings sat unnoticed, not because the dentist was careless, but because they didn't have the training to recognize what they were seeing. And more often than not, that includes routine dental pathology that they should have caught. And so don't miss these things. What does that mean for my students? Every CBCT taken at our school gets a radiology report written by myself, but some general guidelines for after graduation and dentists out there: refer anything if you don't feel confident interpreting everything in the volume. Refer if the CBCT was taken for a specific dental purpose, but the field of view includes anatomy you don't routinely evaluate. Or refer if you find anything suspicious that you can't characterize confidently. And so if you see complex pathology or unusual findings, probably a case where you want to refer. That's what I do for private practice, and there are many other radiologists doing the same thing. Oral radiology private practice is largely driven by CBCT reporting right now. So it's available, it's out there. There's no excuses for missing things anymore. And so here are a few practical tips when you're looking at CBCT yourself. First, know the CBCT anatomy. As I said with radiology, that's kind of the fundamental principle of all radiology interpretation. You've got to know the anatomy. And so if you're interpreting cone beam CTs, you've got to know what it looks like in a CT, which is going to be really similar to what it looks like in a cone beam CT. If you're unsure about something on one slice, then follow it through different slices and different planes. Most anatomy is going to make sense if you trace it across the volume, I've used that trick a lot to figure out what's going on. If you're just focused on one slice, it may look kind of funny in one slice, and then you look at it others and you make sense of, oh, that's what it is. That's what's going on. Use the arch section for any dental-related findings. So anything related to teeth or the alveolar bone, it's easier than scrolling through the axial and coronal. It's really handy using that arch section for looking for dental disease, and where I spend probably a majority of my time on each dental CBCT, only because dental disease is so common. So avoid getting tunnel vision and just focusing on a single area. But remember, it goes back to other principles I've taught. Look through every slice. You're going to look at all the anatomy. And then the last principle here, when in doubt, ask. Send me cases. Reach out to a radiologist. The cost of asking is much lower than the cost of being wrong. All right, so I'm not going to cover these advanced imaging modalities in great detail, but just to be familiar with some of these advanced modalities that are out there, first of all, medical CT, also called multi-slice detector CT or MDCT. It's going to be similar to CBCT and suffer from the similar artifacts. Higher doses than CBCT, but the trade-off is better soft tissue contrast. You can actually see the contrast between white and gray matter of the brain. And so when is this indicated? When you need to evaluate both bony and soft tissue pathology together, like trauma cases, or sometimes complex tumors involving multiple tissues, or anything that extends beyond the oral head and neck area that's going to require more of a medical evaluation. All right, then how about MRI? What do you need to know about MRI? First of all, there's no ionizing radiation. Second, it displays excellent soft tissue contrast, even better than medical CT. So it is the gold standard for evaluating soft tissue pathology, the TMJ disc. So the MRI is the only thing that's going to show the disc of the modalities we've discussed so far. It also displays neural structures, tumors that need detailed soft tissue characterization. The trade-offs, though, are it's slow, it's expensive. Some patients with certain metal implants can't have MRI. Remember, it's a huge magnet. Even though it doesn't have ionizing radiation, this huge magnet can be problematic, and certain safety measures are needed to ensure that patients aren't injured. All right, on to nuclear imaging, something we might not be that familiar with as dentists. Just kind of know what it includes, when it might be indicated. So this includes bone scans, PET, or positron emission tomography, or PET, and then SPECT scans. The indications are for osteoporosis, that's when you do bone scans, osteomyelitis, anytime you suspect a bone infection or bone tumor, or other types of infections and how they spread. And so this is interesting because any nuclear imaging is done by radioactive substances. They're taken in by tumors or infections. Some things take in these substances at a higher rate than others, and then that radiation is read off as part of the image. Of course, the drawback doing that is it's a higher radiation dose than any of the other modalities we've talked about. And as far as diagnostic imaging, nuclear imaging is the highest because you're actually injecting the patient with radioactive substances. All right, then what about ultrasonography, ultrasound? There is no radiation, so very safe. It uses an ultra-high frequency sound wave. And this is used for soft tissue evaluation in the head and neck, salivary glands, lymph nodes, salivary stones, or just looking at the salivary glands in general. So this is something that may be ordered when we see carotid calcifications in a CBCT or in a pano. They can get an ultrasound and look at that artery. They can actually see the blood flow in it, and so they can start to characterize it just with ultrasound before they do further, more advanced imaging. All right, and then this chart sums it up. I don't expect my students to memorize everything here, but this is just kind of a good summary of when these different modalities are used, the advantages compared to others. And I really think for general dentists, if you can't remember all of these, that's probably okay. We're not the ones taking these, right? You mainly need to be able to know when to refer to the patient's physician or to an oral and maxillofacial radiologist when you suspect some pathology that might need imaging beyond what CBCT can show. So yeah, the key thing is just to recognize when a CBCT isn't enough and get the patient to the right specialist. And so that closes out the CBCT for the general dentist. 3 videos. I really shortened all my material to cram it into these 3 short videos, but it is what it is. This will support the rest of the course because we'll be looking at many CBCT cases in the topics ahead. Hopefully now you have enough background to follow along when I show you it's in a scan. That also wraps it up for the introductory content for this course. So topic 1 was anatomy review, 2 was principles of interpretation, the lesions framework, and then 3 is what we just covered, the CBCT topic. And starting the next topic, we'll begin working through specific lesion categories, starting with common periodontal findings. And then after that, we'll move on into well-defined unilocular radiolucencies, the DOA ORCAS acronym group. So looking forward to all these lesions we're going to discuss. See you on the next one. Thanks.